I'll just kind of go back to the backpack analogy, right? When your kids come home with the backpack, all of a sudden the homework is not on the desk where it's supposed to be. It's in the kitchen, kind of spreads all over the place, but it is still in the house. When we give antibody drug conjugates, the chemotherapy does go in, but then it can kind of permeate out of the cell membrane and something right next to it, another cancer cell that might not look exactly like the cancer cell that the chemotherapy was delivered into is affected, and the chemotherapy just kind of goes over to that cancer cell and kills it.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Marisha Pasteris, Office Practice Nurse in the Breast Medicine Service at Memorial Sloan Kettering Cancer Center in New York City, about antibody drug conjugates, or ADCs, in metastatic breast cancer. This podcast episode was produced by ONS and sponsored by Gilead. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Thanks so much for joining us today, Marisha.
Thank you. I'm thrilled to be here.
So to start off our discussion today, let's talk just a little bit about what are antibody drug conjugates, or ADCs, and how do they work differently from traditional chemotherapy?
Sure. So what we know about traditional chemotherapy is that it is a medication that is given and it basically targets rapidly dividing cells. But we know that that therapy does not differentiate between a rapidly dividing healthy cell and a rapidly dividing cancer cell. What antibody drug conjugates are designed is to kind of combine the benefits of a targeted therapy while delivering this cytotoxic or this traditional chemotherapy directly into the cancer cell. When we talk about targeted therapy, one of the most popular targeted therapies in breast cancer was trastuzumab, which was directed at the HER2 antibody that was overexpressed on breast cancer cells. And so basically what an antibody drug conjugate is doing is it's taking the antibody and then it is linking it to a cytotoxic chemotherapy with the idea of delivering it directly into the cell. So how I explain this, even to new nurses or to patients, is a backpack analogy. So if we think of it as a HER2 molecule wearing a chemo backpack, and so it is going to find the HER2 receptor attached to it and then drop the chemotherapy into the cell via the backpack. Similar to like how we come home from work, we open up the key to our door, we're carrying all of our items, and then we drop our own personal items in our house.
I think it's a great analogy to help just really simplify it, because it can be hard to wrap your mind around, especially when we've worked for so long in these traditional chemotherapies or even targeted therapies. This is, as you mentioned, it's almost a blend of both. And so I think analogies work great as we're introducing these new concepts.
Yeah, and I think it's also like kind of those analogies are also helpful, when we're educating our patients, because these are kind of very tricky concepts to understand, right? Is it chemo? Is it not chemo? And these kind of dropping off your stuff in your house is like a nice way to kind of explain it to a patient that might be getting this treatment for the first time.
Absolutely. And so let's talk just a little bit about the people who would be candidates for this type of therapy. Which patients that are diagnosed with metastatic breast cancer would be eligible candidates to receive an ADC therapy?
So this is probably where some of the most exciting developments have come out, even within the last 5 years, is that now pretty much every patient with metastatic breast cancer is likely to be eligible for an antibody drug conjugate therapy. The reason that so many metastatic breast cancer patients are able to receive antibody drug conjugate therapy is because they are targeting two very common antibodies that we see on breast cancer. One is HER2 and the other is TROP2. And these are seen across the board. We see these on triple negative breast cancers. We see them on the hormone receptor positive cancers. We see them obviously on the HER2 positive breast cancers. And now we have a new way to talk about HER2, which is a HER2 low. So these are the patients who historically when we were running pathology tests, these patients were coming back as a HER2 1+, which would not have allowed them to have HER2-directed therapy. But recently, we have found that patients who express low levels of HER2 are able to receive antibody-drug conjugate therapy, specifically fam-traz-deruxtecan.
Just to be able to use this new innovative type of drug delivery for a larger number of patients is really exciting. And it reinforces the need that all nurses need to be aware and familiar about how antibody drug conjugates work and how they are both sometimes similar, but also sometimes different from the other drugs they're familiar with. So an exciting time to be able to share with our patients these new types of therapies. Let's talk a little bit about some of the baseline assessments that we should expect for our patients, to either tests that they need to have performed or any sort of results we should be looking for prior to starting their antibody drug conjugate therapy.
In general, they are very similar to how we start patients on traditional chemotherapy. We're doing our baseline blood work on these patients. We're doing our CBCs, our comprehensive metabolic panels. There are nuances to each of the drugs. So we know that when we give HER2-directed therapy, due to the fact that there are HER2 receptors on the heart, that we need to do echocardiograms prior to initiating any HER2-directed therapy. So, for example, if we're giving fam-traz-deruxtecan, these patients would likely need baseline blood work plus an echo. Another nuanced drug that I'll just call out here is Dato-DXd, and that is a newer antibody drug conjugate. And again, this one targets the TROP2. And again, it would be baseline blood work, but this one has an added need for an ophthalmology exam prior to starting treatment. So while a lot of these ADCs are very common to chemo starts, some of them have nuanced side effects that we need to screen prior to initiating therapy.
Thank you for bringing up those examples. I think those are really important. Now, let's just talk a little bit about some of the common side effects of the antibody drug conjugates. And we've already kind of alluded to this, but it's not really as simple to say it's side effect caused by this drug. It's almost more important to break it down and to say it's a side effect caused by which part of the drug? Is it the backpack? Is it the person? But I think that's what makes these complex, is that knowing that a drug is an antibody drug conjugate is just the first part of the problem. It's then knowing what makes up that conjugate and then what are the side effects associated with that. So maybe at a high level, can you just review some of the more common side effects that we might see for some of the popular ADCs that are being used in practice right now?
Sure. And we have to remember, right, that even though they are antibody drug conjugates and, we're using a lot of terms like targeted and it's going into a certain cell and that should, minimize side effects, these are still very high. I don't want to use this word, but very potent levels of chemotherapy that are being dropped into these cells. So even though these are targeted, these are very potent and strong drugs. So a lot of the side effects that we see, even though we just went through this whole thing about how they're very different from standardized chemotherapy, they are very similar to chemotherapy, right? We see people who have lowering of their white blood cells. Sometimes we have to be giving growth factor in between treatments. So we need to educate patients on infection. Again, a lot of GI toxicities as well. We can see nausea, we can see diarrhea, we can see mucositis. So again, we want to talk about the PRN antiemetics. We want to talk about antidiarrheals, just kind of like the home care that we do talk about with chemotherapy is similar to what we will be talking about when we're talking about antibody drug conjugates as well.
We've mentioned them already sort of in passing, but maybe let's just take a moment to review some of the specific antibody drug conjugates that you've mentioned that are used to treat metastatic breast cancer, and maybe highlight any unique properties or toxicities that those specific drugs might have.
We can go through a little bit by type. So we can talk about a common antibody drug conjugate given in the triple-negative breast cancer setting, which is sacituzumab govitecan. Now, this one has been around for a little bit. And this is one of the therapies that is targeting the TROP2 surface antigen. Again, this is a common one that we see is kind of overexpressing on a cancer cell. Sacituzumab govitecan actually has a black box warning of neutropenia and diarrhea. So those are the two side effects that we monitor closely. And it is not unusual in a patient receiving this antibody drug conjugate to need growth factor, to need a Neupogen support in between treatments or a Neulasta. Fatigue is another real big one with this therapy. This therapy is given 2 weeks on, 1 week off. And a lot of times that's a difficult kind of schedule for a patient to feel well on. So that's one of the ones in triple negative. I just want to also mention that this drug can also be given in a hormone positive patient as well that has failed 2 lines of endocrine therapy and 1 line of chemotherapy. Another one that is just been approved is datopotamab deruxtecan. This is another antibody drug conjugate that targets the TROP2 receptor on a cancer cell. This one carries a lot of side effects. So I mentioned earlier that you need an ophthalmology clearance because there's a lot of ocular toxicity around this one. We see a lot of blepharitis. We see a lot of conjunctivitis. There can be blurred vision. Another thing that we monitor on this one is mucositis. So even in the package insert, there's a recommendation for using ice chips while you're receiving the treatment. So that's another just kind of important nuance related to that antibody drug conjugate. And then obviously in the HER2 positive and in the HER2 low space is the big one, which is Traz deruxtecan. This was approved in 2019 for the HER2 positive patients, then more recently in the HER2 low. And the big one with this one is interstitial lung disease. And that is one of the biggest side effects that we look for when we are giving these patients this drug.
Now, I know a concept that is oftentimes brought up or associated with antibody drug conjugates is this idea of bystander effect. How do you explain this concept of bystander effect to patients and families when you're trying to educate them about these new drug types?
The bystander effect is fairly tricky to understand. I think I read about it many a times before trying to explain it to a patient because I think it can be a little tricky. But basically what is happening is, like I mentioned before, these are very potent levels of chemotherapy. So when we think about, and I'll just kind of go back to the backpack analogy, right? We bring our stuff into the house and then all of a sudden, when your kids come home with the backpack, all of a sudden the homework is not just on the desk where it's supposed to be, it's in the kitchen or it's in their bedroom, or it kind of spreads all over the place, but it is still kind of in the house. So essentially what happens is when we give antibody drug conjugates, the chemotherapy does go in, but then it can kind of permeate out of the cell membrane and something right next to it, another cancer cell that might not look exactly like the cancer cell that the chemotherapy was delivered into is affected, and the chemotherapy just kind of goes over to that cancer cell and kills it.
I love that. Again, the backpack analogy. It's great. It makes perfect sense. Thank you for explaining that. And I think that will be a helpful way to explain it to patients and families when we're providing that education to them as well. Now, you mentioned with one of the drugs specifically that there is a risk for interstitial lung disease. Can you talk just a little bit more about what interstitial lung disease is and why is it important for us to watch for this for our patients who are receiving ADCs?
Interstitial lung disease, it's complicated to understand, but it is essentially an inflammation or a little bit of fibrosis within the lung that causes an impaired exchange between oxygen and carbon dioxide. This was seen in the clinical trials, specifically around Traz deruxtecan. And then during the trials, they had a very small percentage, I think it was 1%, that died due to interstitial lung disease. So this is a very important side effect for us as nurses to be aware of. It typically presents in patients as like a dyspnea. A lot of times it's like, well, I used to be able to walk my kid to the bus stop, but now when I walk there, I feel really short of breath. Or I've had this dry cough for the past couple of weeks and I've tried medications and I haven't had that relief. So we really need to be aware of that because early intervention in interstitial lung disease is key. And how we diagnose it, it varies, depends on kind of how they present. But, there are some patients we will do PFTs on, which is pulmonary function tests. Sometimes, it needs to do radiology, so chest x-rays, CT scans, and sometimes if things have escalated, we do a bronchoscopy to confirm the diagnosis. But again, early intervention is key. If we understand and know what interstitial lung disease is, we see it in our patients, sometimes we're able to treat these things and get these patients back onto therapy.
And so, as you mentioned, the antibody drug conjugates are sort of a new tool in the toolbox that we can offer to patients who have metastatic breast cancer. How do you experience supporting patients as they are trying to manage the side effect profile that comes with these new agents? What are some suggestions or considerations that nurses should keep in mind as we're providing that support to patients when they're at home?
Right. And I think, as we go through our education around cancer directed therapy, we want to make sure they have the appropriate support meds, that they're taking their medications as prescribed, and then really just kind of going through the symptoms that we are most concerned about. And as we know, like early identification of symptoms is the most important thing. We want patients to have an open channel to us to understand that, like, what I always tell my patients is, if there's something that you're not able to resolve, like the cough, we've tried something, we've given an intervention and it hasn't helped, reach back out to us. We know the things to manage nausea. We know the things to manage diarrhea, and we give that education to patients to support them. But we want them to have an open channel back to us to tell us when things are not working. I think that is like the most important thing that we can do is just give real strong guidelines. This is how we're going to intervene. If it didn't work, let us know so we can intervene early to kind of resolve these symptoms.
And as part of that, providing that education to our patients and their caregivers, are there any specific resources that you recommend for them to review? And sort of similarly, as we as nurses are learning about these drugs maybe for the first time, are there any resources that we should be looking at just to stay informed about ADC therapies?
I think there's a lot of wonderful patient education materials out there that are designed to communicate. Like I said, these are complicated drugs to understand. I've seen some wonderful videos from like the Susan Komen Foundation, or, we've had patients listen to talks given by doctors. And this is kind of a great way to get information or reinforce it at home from what the nurse is providing. Same thing with nurses. And I know that this is always like a very dorky thing I recommend, but I honestly think package inserts of drugs are great.
Not dorky at all. Very informative and truly the source of truth. So I love that you say that and you call that out.
And those package inserts are generated by a clinical trial team and generated with the help of nurses. So I just feel like those are really a great asset for us as nurses to understand, like, what are the main side effects we need to look out for? How often do they present? At what grade do they present? Like, I do think it is helpful to look at the inserts, even though, a lot of times the institutions that we work at have these very robust educations or patient educations that we can also look at. But I do think the package insert is like a great place to go for a nurse. And then obviously, like going to the ONS website, we just did a wonderful case study regarding antibody drug conjugates. And, like all the usual players like ASCO and the NCCN guidelines, these things are very helpful for nurses. And then just circling back to patients, I also think the manufacturer website can be a great guide for both patients and clinicians.
Absolutely. I agree with that. When you're talking with patients and counseling them on the drug that they've been prescribed as their treatment plan, how do you address or approach questions about the benefits or the risks of antibody drug conjugates, maybe compared to other therapies that they've been on before, or maybe were other options that they could have considered?
I think an important thing is to be realistic. A lot of times people are like, oh my gosh, the antibody drug conjugates, they're like all the new thing. They're, I want to have this therapy, et cetera, et cetera. But they are toxic drugs. They have the benefit of being targeted, but we know that they carry a lot of side effects with them. I mean, it's like almost kind of interconnected, right? Their specificity makes them so wonderful. And we've seen amazing responses to those drugs. But also, we want patients to be safe. We want to give these drugs safely. So we have to assess our patients and make sure that this is an appropriate patient to give this kind of therapy to. I think that's like an open conversation that clinicians need to have with patients regarding these drugs.
And what would you say are some key takeaways for nurses maybe to bring back to their site of practice after either listening to this podcast or, as you mentioned, engaging with the case study that we will also be linking in the episode notes today? What are some of the key takeaways that we can bring back to our colleagues and share?
I just think understanding some of the specific side effects around the drugs is really important. They are nuanced. We have ocular toxicity in one and interstitial lung disease in another. And so I think it is important for nurses to understand what to look for. Same way we in our chemotherapies, right? We know that taxanes cause neuropathy, and we know like combination adriacytoxin is like an antiemetic support. We need to familiarize ourselves with the antibody drug conjugate therapies and their nuanced side effects so we're able to better educate our patients about what to expect while they're on these treatments. And then I just think another important thing is just like assessing our patients, right? Like, is this an appropriate candidate for therapy? Is this safe for the patient? Do they understand the treatment? Are they able to report back side effects to us effectively? I think all of that is really important when we're giving these drugs. They're incredible drugs and we've seen amazing results, but we have to be aware and vigilant about their toxicities.
Well, Marisha, thank you so much for joining me today on the podcast and sharing all this great information about antibody drug conjugates and how they are used in metastatic breast cancer. I think this is a valuable topic, and I know our listeners will appreciate hearing all that you have to share on this. Do you have any final comments to share with our listeners?
I think I do.
All right. Well, thank you so much again for your time.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.